So hello, thank you for joining us today for a perinatal webinar covering the topic maternal levels of care, why now and how California is impacted. I would like to welcome everyone who is participating. My name is Liza Alvarez, and I am the administrative assistant here at PACLAC. Everyone participating today has the option to receive one CEU contact hour for continuing education. In order to receive this unit, you must complete the survey that will be sent to your email. There will be time for questions at the end of the presentation, so feel free to write your questions in the designated area in the GoToWebinar comment box as they come to you, and we will hold them until the end of the presentation. Lastly, I would like to introduce our guest speaker, Sarah J. Kilpatrick, MD, PhD, who is the helping hand of the Los Angeles Endowment Chair in Obstetrics and Gynecology Professor and the Chair of the Department of Obstetrics and Gynecology and Associate Chair for Faculty Development at Cedars-Sinai. She has received numerous awards for teaching and services and has served on many national OBGYN organizations, including President of Society of Maternal Fetal Medicine. She is currently the Associate Editor of the American Journal of Obstetrics and Gynecology and on the editorial board for Contemporary Obstetrics and Gynecology. She is board certified in obstetrics, gynecology, and maternal fetal medicine. Her clinical and research focus is on extreme preterm delivery and maternal morbidity and mortality. Dr. Kilpatrick will be presenting on the proposed classification system and what it all means in regards to improving maternal risk appropriate care. So without further ado, let me hand over the floor to Dr. Sarah Kilpatrick.
Well, thank you very much, and thank you for inviting me to give this presentation. It is on a topic that I am very passionate about. So let's just get started. If I can make them, there we go. So somehow the slides are not moving. Oh, there we go. So there are the learning objectives, of which hopefully by the end of the talk you will all easily be able to address. I'd like to intersperse this talk or start this talk with some examples of patients that that illustrate why we need to do this. So in whatever your setting is, if one of these women showed up at 3 a.m. in the morning, a 25-year-old at 35 weeks who had HELLP syndrome and DIC, excuse me, a 42-year-old at 38 weeks who had acute fatty liver pregnancy, a 20-year-old at 36 weeks with flu that progresses quickly to ARDS and now she needs to be ventilated, a 34-year-old at 36 weeks who has known pulmonary hypertension and just shows up in labor at 3 in the morning, or a 40-year-old at 33 weeks who's had 2 prior cesarean sections and a suspected accreta who shows up with ruptured membranes. So the question is to each of you in your own hospital setting, how would these patients be handled at 3 in the morning? And the goal ultimately with the maternal levels of care is to facilitate in the best possible fashion, and particular to the institution, how best to handle these women. Sorry about the slides, don't seem to be responding to moving forward. Oh, there we go. So now I'm just going to give you some background about why this effort is needed right now in the United States. So we know that the maternal mortality rate is going up in the U.S. This is a paper that came out in 2014, which really was embarrassing to the U.S. You can see that the blue columns are the 2013 and red 1990, and the circled columns there is the United States. We are the only country in this range of countries who are somewhat similar to us in terms of their socioeconomic status, where the maternal mortality went up. In all these other countries in this same time frame, it went down. Again, I'm sorry about having trouble getting slides to forward. There we go. Here's a graph that shows the maternal mortality in California, which is blue, which is us, and the U.S., which is red, from 1999 until now. And you can see that the red line has continued to go up and continues to go up today, while the blue line went up till about 2006 and then has fallen. And much of that may be, in fact, due to the work that California has been doing through the CMQCC. This is another way to look at this. This is a great interactive graph, or table, sorry, graph, I guess. that is from the CDC, from the Maternal Mortality Health of Women and Children report, and you can click on any state, and if I'm not going to do it because it takes so much time, but it will give you the actual state values for a number of issues, including maternal mortality. California right now is number 2 in the country for the lowest rate of maternal death. Number 1 is Massachusetts. The worst state is Texas, and Washington, D.C. is the absolute worst for maternal mortality. This is another way to look at this. This is broken down by ethnicity and by maternal age. And what really stands out on this graph are the orange lines, which are maternal age of 40 and over. And when at every single ethnicity, those women have the highest rate of maternal deaths. And this is what pregnancy mortality out of 100,000 live births. And in the African American Black women, you can see that this rate is outrageous at 192 out of 100,000. And clearly we have work to do in this country with respect to ethnicity and, of course, dealing with increasing maternal age. This is data from Elliott Main's paper that summarizes a review of California deaths from 2002 to 2005. And the question here was, what % of these deaths had an opportunity or a chance to alter outcome? Could they have been prevented, in other words? And the blue color is good to strong chance. So that really means that probably all of those deaths that were rated in this blue color were probably preventable. And what you can see from this graph is that the obstetric hemorrhage had the highest rate of preventable deaths. 70% had chance to alter outcome in hemorrhage, and compared to cardiovascular disease, which was much lower. So this really helped us look at where we can put our efforts to improve outcomes. This is another same paper, a different way to look at the data, and this is asking the question, in those cases that have some opportunity to alter outcome, what were the provider factors involved? And this is very important. And the blue in this case is delayed response to clinical warning signs, and red is ineffective care. Those are the two most common aspects to provider-related issues, and you can see that upwards of 80% or more of these cases with opportunity to change had provider-related issues around delay in recognizing a diagnosis and therefore intervention. This is due to facility factors. First point I want to make is you can see that the % of cases that had facility factors in terms of improvement in outcome are much lower than the provider factors. But the dark blue here is inadequate knowledge, and that was the most common in all of the diagnoses. So it's something else to keep in mind. And finally, patient factors. They did have patient factors, but in general, the patient factors were less controllable by us. Underlying medical condition is blue, and then the red is obesity, which we can talk about later some more if you'd like. One last graph depicting this, and what I want to point out here is the pink. The pink means delayed response to triggers and ineffective care, most common factor related to provider factors related to maternal death. So this is where we can do a better job in terms of educating our providers. So that was all death-related data. Now let's look at severe maternal morbidity. We know death is increasing, but it's actually not very common, which is the good news. Only about 700 to 800 women die a year in the United States, a number that's too high. But for any individual hospital or provider, that will be very few. However, women who get really sick but don't die is much more common, 50 times more common than death, and probably affect well over 50,000 women a year in the United States, and this number is also increasing. So there are more women who are getting sicker in the United States as well. Here's a graph of that. You can see the time frames on the x-axis, and you can see that this is increasing. So clearly illustrative of a problem we need to address. I'm going to skip that one. So how can we show that these women who are really sick but don't die, are they similar to the women who die? Can we make the argument that we could study these women and be able to generalize to factors related to maternal death? And this is a paper I did now well over 10 years ago with Stacy Geller. We asked that question, and we looked at a relatively small sample, but women who we compared the preventability rate between deaths and women who had near misses, we called them, which was they were very, very ill but didn't die. And you can see that the rate's the same. So the near misses, the very sick women, had the same proportion of cases that we thought were preventable as the deaths did. So that means that they're similar to the women that die. And we also found, just like the Elliott Main data for death, that provider-related preventable factors were significantly related to progression from being very ill to being a little ill to being very ill to dying. So once again, focus on the provider. The similar issues that we found, the same as the California data, this is data from Illinois, my data, incomplete management, #1 cause. These are the types of provider and communication, and system issues, again, similar to the California data, and remarkably, the numbers are quite similar as well. So the issue about prevention of morbidity, which is going to be related to our levels of maternal care, it's very important as we review these cases to you either prevent the death or you don't. The morbidity question is harder. We're not likely potentially to prevent the actual preeclampsia, but maybe we can prevent the eclampsia or the patient who gets sicker because she doesn't get delivered soon enough and gets DIC, etc. So as we talk about reviewing cases, that's going to be important to keep in mind. This is a recent paper we did here at Cedars looking at the question of what are the opportunities for improvement in severe maternal morbidity cases. We looked at cases between 2012 and 2014. We screened for these cases by looking at all women who had an ICU admission or who had were transfused of 4 or more units of blood. We also screened using some ICD-9 codes similar to what the CDC had used in their papers. So we wanted to pick up all of our women here who met the criteria for severe maternal morbidity. Once we found those cases, we then screened them quickly to see if they really were that sick. Sometimes someone who goes to the ICU isn't that sick, that's just prophylactic. And then we reviewed each case with a multidisciplinary team and asked the question, was there an opportunity for improvement in her outcome? And was that strong, possible, or none? And we used the California terminology that Elliott Main's group has been using. And then we asked if there was an opportunity, was it related to system, provider, or patient, or all three? This is a little cartoon. We had 16,000 deliveries in this time frame, and ultimately we found that 150 of these women had true severe maternal morbidity. So our rate is about 0.9% of all the deliveries, and that's important because it's really not a high rate, which is great, and most people are reporting 0.5 to 1.5, so we're sort of in the middle. And then each of these cases was reviewed by a multidisciplinary team that I just described to determine on whether there was an opportunity for improvement in care. And what we actually found, unfortunately, I wish it were better, but unfortunately was that of all of our cases, 44% of these women who had a severe maternal morbidity had an opportunity to improve their care. What we also found is, once again, provider, the most common category of improvement was in the provider category, nearly 80% of them. Far fewer had system or patient issues. And I think the final point I'll make is that our #1 cause of severe maternal morbidity in this time frame was still hemorrhage. Hemorrhage did have one of the lower rates of improvement, which is good. Maybe that's because we're doing well with the CMQCC guidelines, etc. So that's important, basically to say, look, every obstetric hospital needs to focus on improving their outcomes, and all of us need to review our cases of a severe maternal morbidity and, of course, mortality to look for opportunities for improvement. In terms of, this is a table that I'm shifting slightly, but to show you in the United States, what you can see here is that the number of hospitals is on the y-axis, and the delivery volume per year is on the x-axis. So Cedars, we're in this category right around here. We're around 7,000. Most of the hospitals in the United States deliver far fewer. Most hospitals deliver under 2,000 deliveries a year. And when you think about that, that means that their volume is low. They're not going to have that many really sick women or that many women that die. and yet most of the deliveries in this country go to small hospitals with low delivery volume. So how do we help those hospitals? How do we work together with those hospitals to make sure that they have the capabilities that they need, and or make sure that they have easy communication at 3 in the morning with a higher level of hospital that they're a partner with? So the topic of levels of maternal care is not new. In 1976, there was this document called Toward Improving Outcome of Pregnancy, and in that document, what is that, 42 years ago almost, it was strongly recommended that there should be both regionalized perinatal care, which means both mothers and babies. The neonatal aspect was actually taken quite seriously and is relatively universally established across the United States. However, the maternal level aspect was virtually ignored. And data in the neonates does support that if once they had neonatal levels of care, they actually dropped their neonatal mortality. So from the maternal end, though, these levels should matter. We should care just as much about mothers as we care about babies having the right care at the right place when they need it. We have a very difficult to find data, however, to prove that having maternal care at the right level, at the right time, makes a difference. There are a few studies here that suggest it might. OB complications were more common in hospitals with low delivery volume. That's one paper. Low volume providers had significantly more OB complications. That's another paper suggesting that volume may be an issue. And finally, maternal mortality was inversely correlated to population density of MFM. So areas that had fewer MFMs had higher mortality than areas that had more MFMs. So these are not perfect examples of data, but they're about the best we have out there right now to suggest that matching level of ability and seriousness of maternal disease may improve care. Okay, I don't know why sometimes this works and sometimes it doesn't work. All right, I can't seem to move this slide. Oh, there we go. Okay. This is the neonatal data that shows that in 1965, when they started to really do began to do regionalization, then again here when that document came out, they really did drop neonatal mortality. So, oops, went backward, went too far. So this is a picture of the document that came out in 2015. It was a multidisciplinary document. There are many of us and many conference calls and meetings to put this together. It's the Levels of Maternal Care, LOMC, and the goal here would be to articulate why we think that this is important for best maternal outcomes in the United States. And the idea is really matching the care that she needs at the time she needs it with the right site, with the concept that no one wants to take women out of their community. If she has the right care in her community, then she should stay in her community. This is not about moving patients that don't need to be moved. It's about building relationships between hospitals across levels so they feel like they're partners. They feel like they can provide the best possible care for any woman that walks into their hospital with their partnerships. Most of those women are not going to need to go anywhere except to stay in their community. But the few that do need to go someplace, or the few that need extra help, are often not planned, and there needs to be a system in place to be able to deal with them. It was also important that we align multidisciplinary women's health groups in this process, and ACOG, SMFM, American Association of Birth Centers, ACNM, AWAN, AAP, SOAP, which is the Society of Obstetric Anesthesiologists, and the birth centers were all participated in the development of this document deliberately because we all care about the best possible care for women. We think that maternal levels should be complementary but distinct from neonatal levels. So the framework should be the same, but you could in fact have a hospital that might be maybe it's a neonatal level 1 and a maternal level 2, or vice versa. They don't have to go together. They often do, but they don't have to. It's important that we're looking at all aspects of maternal care, and ultimately we need to gather some data and quality focus to see, once we get going, if we can show that it makes a difference. This is essentially it says the same thing. We wanted to come up with standardized definitions and nomenclature for the levels and guidelines for each level. This was a work in progress. The framework was similar to neonatal. We did sort of have to create some definitions the best we could from available data and from expert opinion. The goal also was to recognize that the geography of the United States is quite different. So Southern California is very different than Northern California. And California is very different than Wyoming, for example, in terms of what's available and what's possible, and that needs to be kept in mind. So the essential components here are listed. You can see that some of these slides were from ACOG, but the main point I want to make here, I've already said most of them, but I want to really emphasize that the relationship piece between lower and higher levels of hospitals, and that the direction of interaction goes both ways. So in the perfect environment, the higher level hospital helps provide education for the lower level hospitals, in addition to helping them with care provision. Helps with their quality metrics and quality programs, for example. And this is not about trying to close small hospitals or level 1 hospitals. It's about making sure that those level 1 hospitals that are often in rural areas with very few hospitals around are aligned with higher levels of hospitals that can help them, that's geographically efficient. Here are the levels. This is the first time ACOG actually used or talked about a birth center. And in this document, we basically say a birth center may be appropriate as long as it meets the birth center and the national AABC requirements. It is not a level 1. There was some misconception about that. It is not the same as a level 1, but ACOG anointed them as saying they're appropriate if they meet the requirements in their own organization. Then level 1 or basic care, excuse me, level 2 or specialty care, level 3 subspecialty care, and level 4 regional perinatal health center. This is where we started, and these are the 4 levels that we then focus on in the document. The birth center we do a little bit, but I'm not going to talk any more about that at the moment. So there are the 4 levels. The definition is listed there. I did send the document around. I don't know if you all have the document, but this is all taken from that document. Basically, basic care, uncomplicated pregnancies. However, the institution has to be able to stabilize and manage unanticipated problems. Specialty care would be everything required in level 1 plus a little more depth and appropriate high-risk conditions. Level 3, subspecialty care, would be everything required in level 2 plus the ability to care for more complex maternal medical conditions and OB and fetal conditions. And then the level 4 would be all of that plus really the ability to care for the most sick women and have the most other subspecialists, i.e. neurosurgery, transplant, cardiac surgery, that type of thing. Again, this is, I'm just going to do a couple, I'm not going to go and read the whole document to you because it's very detailed, but I'm just a couple slides on each area. So birth center, uncomplicated, low risk, singleton, vertex. They still, by their own criteria, have to be able to initiate emergency procedures. They have to have an established agreement with the receiving hospital. That's their criteria, AABC, not ours, but we agree with that. And they need to have medical consultation, quote, at all times, and that means by phone. Basic care, level 1. Ability to begin a cesarean delivery, and this is the new ACOG terminology. The 30-minute terminology is gone, by the way. The new terminology is, quote, within time interval best incorporates maternal fetal risks and benefits. That's very vague on purpose, but we all know that that 30-minute rule was made up, and 30 minutes is not okay for a cord prolapse. It is not okay for a uterine rupture. So we felt at ACOG that it was better to get away from the actual time, and hopefully the judgment of the providers is the right choice. Level 1 has to have protocols. Level 1 has to have OB with privileges for cesarean delivery available. That does not mean in the hospital. It means available to come in. Same thing with anesthesia. Available means available to come in, not that they're necessarily in the hospital. We did say that level 1 could do term twins, TOLACs, and term preeclampsia without severe features. Level 2, basically more stuff. I'll just highlight what's in red here. The OBGYN has to be available at all times. The MFM has to be available for consult in a level 2, not in the hospital, but consult on the phone at least. And anesthesia has to be available at all times in a level 2. Level 3, more stuff. And then this is where we start talking about ICU interaction. In a level 3, the ICU accepts pregnant patients who need critical care, and they have critical care attendings on site that collaborate with MFM. There has to be an in-house OBGYN 24 hours a day in level 3. So that someone has to be in-house 24 hours a day. There needs to be an MFM with inpatient privileges. So in a level 2, the MFM could just consult on the phone. They don't have to be able to have inpatient privileges. At a 3, they have to have inpatient privileges and be available at all times, and many more subspecialists. And then a 4, again, more stuff, but perinatal system leadership, be able to do outreach to help their related hospitals. And the MFM care team has to be able to co-manage critical patients in the ICU. So they have to be able to be on site with at least one or multiple notes during the day. They're co-managing with the critical care docs. And they have to be available to come on site 24 hours a day. They don't have to be in the hospital 24 hours a day. They have to be able to come on site, though, whenever they're needed. All right, these are just patient examples. I think I mentioned the level 1 already. Level 2, severe preeclampsia, previa, no prior surgery, and then 3, accreta, previa, prior surgery, etc. And then 4, much sicker patients. They're just examples. They're not requirements, they're just examples. So ACOG then, with SMFM and CDC and the Perinatal Arizona Trust, put together a verification program where we actually asked for hospitals to volunteer for us to go visit them to essentially test. Does this system work? Does this leveling system we put together, can we essentially confirm a hospital is level 1 through 4? And so we did that. The process was that after they volunteered, they would complete an online application. We would do a site visit, and then we'd send back a report. We worked with the CDC, who had done the locate tool. Some of you, if not all of you, are familiar with the locate tool because California did that from the CDC. We looked at the data that the CDC had for these hospitals, and we compared what the locate tool collected with our own data that we collected. The CDC locate has been implemented in 12 states and Puerto Rico. This is what the locate tool looks like. You've seen this if you've done it. I'm not going to spend any more time on that. And then, so we developed our own assessment tool based on the document I just reviewed, the OCC document on levels of maternal care. We did have input from the locate tool as well. And then we set up these site teams that I went to several of the hospitals, but not all of them. And we had MFM, OBGYNs, family medicine docs, nursing personnel, and administrative people. Some combination of those people went to each site, and someone from the CDC. And on the site, we met with the hospital team that they put together. We asked for specific types of people to be there. We met with them, and then we discussed our assessment tool. We went through questions, and we discussed with them what their capabilities were. And once we did that, we had a caucus. The site visit team had a caucus, and we then discussed some of the issues on site with them the day we were there, and then less important issues, we actually summarized our findings and sent them back a report and said, basically, yes, you meet a level 2, except you need to do this, or you meet a level 1 completely, and if you want to go to a level 2, you need to do this, this, and this. We started this in 2017 in March. We then actually completed it, these were the teams that were the types of people that we included, which I just alluded to. And then we actually completed this process, this site visit in September. So between March and September we did this. We went to a total of 14 hospitals, Georgia, Illinois, and Wyoming, so great geographic variation. Illinois included parts of Chicago, and Georgia included near Atlanta and also rural. And the conclusion from that process was that each of the hospitals that we visited were really happy to have us there. It was a great dialogue. We learned a lot about how hospitals differ across the country, and their region makes a huge difference. It was very impressive, the lower level hospitals in the rural areas, how much they could do. And we also realized that the hospitals were very happy to talk to us about this issue and to help facilitate connections with other hospitals. So, switching topics a little bit, if California, if we did all this in California right now, how would they look? This is a study based with Kim Gregory's group here at Cedars that was published 2 years ago with Korst as the first author. And what they did is they did a cross-sectional survey of all California hospitals. They actually called, someone on their research team called to each labor and delivery unit to talk to their nurse manager. They asked about characteristics for basic, intermediate, and regional care. They used slightly different definitions than we use for the document, but close enough. And they talked to almost every hospital, so 239 out of the 248 hospitals. That's quite a bit of work. Oh, did I go the wrong way? Let's see, sorry. Okay, can't get it to move again. I don't know quite what to, oh. For some reason, okay, here we go. All right, sorry about that. I don't know why I was going backwards. So this is a table from that paper. And what's really interesting is when they analyzed all their data and then they said, okay, what level does each hospital fall in based on our interviews? Here's what they found. So in California, 48%, nearly half the hospitals didn't meet any level. I mean, this is shocking. 48% met no level, not even basic. So I think this is a real eye-opener that either we're way off on what we think they should have, or we really need to focus on getting everybody the right resources that they need to meet these levels. Only 15%, so only 34% of hospitals met any criteria. And look at that, in the entire state, only 5 met regional criteria. Only 15% of all the hospitals met basic criteria. So that really suggests that there are a lot of hospitals doing obstetrics out there that don't meet basic criteria. And the key thing that they were missing, they used the 30-minute rule in their paper, lack of ability to perform a cesarean delivery within 30 minutes, 100% of the time. Lack of availability of a pediatrician day and night. Now that's not in our maternal levels, but that's pretty amazing. And lack of ultrasound capability within 12 hours. So these are things that you would think that any basic hospital that does obstetrics should have. So it's very shocking. I'm going to skip the neonatal piece. So there are states out there that are doing this quite well and have state-based maternal levels of care and have been doing it for quite a while. Arizona is sort of the poster child. They've been doing it since 1980. It's voluntary, but every state does it. Indiana, Maryland, and Illinois also has a system as well. So, and from my perspective, I really think we have to do this. I think we did it for babies. I think mothers deserve absolutely the same level of care and concern as the babies do. There are clearly barriers, geography that we cannot change, so we have to be creative how we handle rural hospitals. And frankly, you could argue that the LA area, for example, we are not that large. We have lots of hospitals, but with the traffic, the time frame of getting to and from hospitals can be a huge barrier. There is a cost to this. Some of it's real, some of it's a perceived cost. Part of the cost is just human cost of human time, but there are other costs as well, and that needs to be thought through. This is a graph, again, you've seen similar, but this shows our increasing maternal mortality by race and ethnicity, and you can see the big increase, and this is California data, so this is the good news, but so increase until 2005-07 on everybody, essentially, but then we started this nice decrease. So for white, non-Hispanic, it's now down to where we were in 2001, 1999, which is terrific. If we look at African American, you can see the increase. It is coming down in California, which is great, but it's still, even in 2013, the rate, it's still almost 4 times worse than Caucasian women, which is a problem across the country and needs a lot of work. And I guess what we could say is the good news, it's not as bad as this, but it's still much higher than it should be, and it needs a lot more attention. So I mean, I have a little bit more time. I'm going to talk about a few things about what we can do in addition to levels, about how can we help improve outcomes in women. And this is the question of, the standard in CMQCC and ACOG has been to treat women who have severe hypertension and pregnancy, to treat if they're 160 or greater, or 110 or greater, or 105, depending on which number you use. And that mandate came from an old paper from Jim Martin from years ago that was a retrospective study, but no one has ever shown that treating women that quickly, to treat them within an hour, actually makes a difference. It makes sense that it would, but it hasn't been shown. So we asked that question here at Cedars, and we had a paper that is in press at the moment. We looked at women with severe hypertension between those 2012 and 2014, and we defined timely treatment if they were treated within an hour of confirmed severe hypertension. So they get one blood pressure that gets repeated within 15 minutes, it's still high. From that time on, do they get treated within an hour? We had a lot of women with severe hypertension, so 465 women all had severe hypertension in this time frame. 56% of them actually were treated within an hour, but 44% were not, and that's here when we should be able to do that. 18 of these women who had severe hypertension had a severe maternal morbidity. So the question was, when we compare the timely treated to the not timely treated, could we show any reduced rate of severe maternal morbidity? So I'm still waiting. My little button is not working so well again. Okay, so here it is. So here are the results. Sorry, it's a little bit small. So the first thing to note is that when you look at the mean or median blood pressure before treatment, it's not different between the women who ultimately had a severe maternal morbidity, which means they ultimately got really sick, went to the ICU, had 4 more units of blood, or had some other marker of severe illness. It was 170. And the women who ultimately did not have one of those things, it was 167. So you can't tell from their initial blood pressures how sick they're going to get, just by initial blood pressure. Both groups got the appropriate initial dose, so 80%, more than 80% got the right initial dose of whatever drug they got, which is great. What's interesting is the group that ultimately went on to have a severe maternal morbidity had a significantly higher number of doses. They had a median of 5.5 doses compared to 2 doses in the women who did not get so sick. And they also, the women who got really sick, developed severe maternal morbidity, also had a high rate of more than 2 or more different medications. So nearly 3/4 of them, 72%, needed 2 or more different medications to control their blood pressure, versus only 1/3. So initial blood pressure doesn't tell you, but the more doses of medication you need and the more different drugs you use is a clue that you're dealing with a woman who's likely to get really sick. So the question we asked, though, was there any relationship between timely treatment and rate or incidence of severe maternal morbidity? And the answer is yes. So those women who were not timely treated, they had a 6% rate of developing severe maternal morbidity versus a 1.9 or 2% rate in the women who got timely treatment. And remember, our overall rate of severe maternal morbidity in this time frame was about 0.9%. So both groups of these women had a higher rate from the overall. But it's really important message that this tells us that timely treatment within an hour of a severe hypertensive episode is associated with better outcome. All right, so let me go to the next. So this, I think, is my last slide. So essentially, this is a presentation really trying to convince you that moving toward real designations of maternal levels of care is important. That the goal is to align the right care for the right woman at the right time. And a major premise of this goal is to build relationships between hospitals that regionally make sense and that can partner with each other such that they both have what they want, which is the best outcome for the mom and, of course, the baby. But that the partnership allows easy access 24 hours a day, and an easy discussion back and forth about what the best thing to do for that patient, whether it is to stay where she is and be treated there or to be transported, etc. So I'm pretty sure that's my last slide, and I am very happy to take any suggestions or questions. Thank you very much.